What's up, Ninja Nerds? In this video today, we're going to be talking about anemia, but we're going to go through 3 parts. We're going to have microcytic as one video, we'll do normocytic as another, and then we'll finish off with macrocytic anemia. Now, again, this is a part of our clinical medicine section. If you guys like these videos, they really help you, you enjoy them, please support us. You can do that a couple different ways. Hit the like button, comment down in the comment section, and subscribe. Also, really highly suggest this, and I'll continue to do that because I really think it'll benefit you. If you guys could go down the description box below, go to our website. On our website, if you guys become a member, you'll have access to thousands of notes, illustrations, tons of quiz questions, things that'll really help you to amp up your studying level and take you to the next level. So please check that out. Without further ado, let's talk about microcytic anemia. All right, so let's begin our process here talking about the pathophysiology of anemia. So real quick, and I don't want to go too crazy because anemia, a simple definition, is really all it is. It's a decrease in red blood cell mass. Now you're probably like, okay, Zach, that already sounds, how am I measuring this? The easiest way to determine anemia is looking at what makes up most of the mass of the red blood cell. It's hemoglobin. Hemoglobin makes up like 97% of the red blood cell. So really, when there's a decrease in red blood cell mass, there's a decrease in hemoglobin. So you have to kind of go back a little bit. So you have to know that, again, there is what's called your red bone marrow, right? Now the red bone marrow is the site of not just erythrocyte production, so erythropoiesis or red blood cell formation, it's also the site of all blood cells, really. White blood cells, platelets, in addition to that. So red bone marrow is responsible. Really, whenever you kind of dig into it, you have these like stem cells, right? And the primary one that helps to make red blood cells is called your myeloid. So your myeloid stem cell. This is the one that really helps in the process when it goes through the erythropoiesis process. It will help us when you go through erythropoiesis. We'll write that here on the side. Erythropoiesis. This is the production of red blood cells, right? So you're stimulating the production of red blood cells. Now, these red blood cells, when you actually look at these RBCs, right? What's interesting about these is that when you look at the component of them, so once you actually have your red bone marrow, inside of the red bone marrow, there's tons and tons of these myeloid stem cells that are constantly undergoing differentiation, replication to make red blood cells. These red blood cells, when you actually take and zoom in on these puppies, guess what they're made up of? When you look at the composition, it's hemoglobin. So here's going to be our big hemoglobin molecule. So whenever a patient has anemia, right, what we see is that there is a decrease in the erythropoiesis process. So something is decreasing this process. This process is actually in some way, shape, or form being impeded. So there's a decrease in the number of red blood cells that are being formed. If there's a decrease in the number of red blood cells, there'll be a decrease in the hemoglobin. If there's a decrease in the hemoglobin, at what point do we define that as being anemic? That's a great question. So we say that whenever the hemoglobin for a male, and this is not perfect, it's kind of like at least a generic term, but for a male, it's when it's less than 13 grams per DL. And then for a female, it's less than 12 grams per DL, right? So less than these, we now have anemia. So there is a decreased amount of hemoglobin within our red blood cells, right? Now, when we talk about hemoglobin, it's made up of 2 components here. This component here is going to be, and I'll have it over here, this is our heme, right? This is our heme, this component here, these little black parts here with the 2 positive symbols. That's our heme. And then these parts here, the red and blue ones here, this is the globin, right? So this is the globin. And what happens is in patients who have microcytic anemia, which is a hemoglobin in males less than 13 or hemoglobin in females less than 12, we determine microcytic anemia as being when the hemoglobin's low, but the size of the red blood cells are very small. We'll talk about this in the diagnostic section, but oftentimes the way that we define microcytic anemia, and I'll write this here for right now, is when the MCV is really low, all right? And all that means is that the size of the red blood cells are very low, or very small, okay? So what happens is in patients who have anemia, microcytic anemia, they have less hemoglobin that makes up less of their red blood cells, and their red blood cells are very small and tiny, right? The concept that you have to think about this pathophysiologically is what's actually leading to less hemoglobin, leading to less red blood cells that are being formed. That's a great question. In this process, there's some abnormality that exists here within the heme. So maybe there is a decrease in the heme, and that's supposed to make up hemoglobin, right? So this is our hemoglobin, this whole molecule here, right? If there's decrease in heme, there's less hemoglobin. And if there is a decrease in globin, there's less hemoglobin, less red blood cell mass. The red blood cells are very small, and that's how we would define anemia. So now what we have to do a little bit here is kind of say, all right, I know that anemia is when hemoglobin is less than 13 in males, less than 12 in females. Microcytic, it just means that they're really, really tiny. The MCV, the mean corpuscular volume, is low. If you really want to know, but we're going to talk about it later, I promise, but to just wet your palate a little bit, it's less than 80 femtoliters, right? And again, this is grams per DL, just for units, right? This is the way that I want you to think about this. What's causing a decrease in heme production, or having less heme, and what's causing a decrease or absent of globin production? If these two are deficient or absent, you have less hemoglobin, less of that to fill the red blood cells. The red blood cells get small. That's what we have to think about. Let's do that now. Decreased heme synthesis. You know what the heck? Like heme is really just kind of like these pigments combined with iron. That's really all it is. It's protoporphyrin, which is a type of pigment, combined with iron. That's all it is. So when we look at this, we're actually going to be kind of zooming into this stem cell. So all of this process is actually occurring in these stem cells all the time because they have to synthesize the heme to make the hemoglobin in the red blood cell. So when we look at this, there's two components in the cell where a lot of the heme synthesis is occurring. This is more the basic fundamentals, but we'll kind of quickly go through the most important points. In the mitochondria, there is a lot of parts of heme synthesis that are involved, and in the cytoplasm, there's a lot of parts of heme synthesis involved. I don't want to go crazy. I want to give you just the important parts that you need to know that's clinically relevant. So there is a molecule that we actually have. It's an amino acid. It's called glycine. And glycine, when the mitochondria, it combines with another molecule called succinyl-CoA. You're like, oh, that sounds familiar. That sounds like biochemistry goodness. What is that? Oh, that's the guy from the Krebs cycle. So I got an amino acid and I got a Krebs cycle intermediate. If I combine these two, right, in the presence of this beautiful, beautiful enzyme, what I do is I make another molecule, right? And this enzyme is actually important to remember. This enzyme is called ALA synthase. Very, very important enzyme in this heme synthesis process. So this is this enzyme, and this enzyme is catalyzing this step. It's supposed to stimulate this process, all right? And what it does is it actually helps to take glycine and succinyl-CoA, combine them together and make something called ALA. ALA is amino-levulonic acid, all right? What happens is amino-levulonic acid then reacts with another enzyme. You see this enzyme here? This enzyme is called ALA dehydratase. ALA dehydratase. And what this enzyme does is it helps in this process here. I'm actually going to bring this enzyme closer so we have it here. But what it's supposed to do is it's actually going to help in this process to convert, right? It's going to convert ALA into what's called porphobilinogen. You're like, bro, Zach, do I gotta know all this stuff? I promise it'll come in handy when we think about how these different types of anemias come into play. Now this is gonna help to stimulate this step, all right? So it's gonna help to drive this step. Now what happens is, porphobilinogen goes through a bunch of other intermediate steps that we don't really need to know. I'll use it through like a bunch of different arrows, but then eventually what happens is, it gets taken back into the mitochondria. So the glycine and succinyl-CoA use the enzyme in the mitochondria called ALA synthase to make ALA, push it out into the cytoplasm. This cytoplasmic enzyme ALA dehydratase converts the ALA into porphobilinogen, goes through a series of intermediate steps and gets pushed back into the mitochondria. When it gets pushed back into the mitochondria, eventually it gets converted into something called protoporphyrin. And particularly the type that we care about is 9. But for right now, protoporphyrin. I gotta spell that better. Protoporphyrin. And this is protoporphyrin 9, technically. Now, once protoporphyrin is there, we use another enzyme. This blue one right there. This enzyme is called ferrochelatase. Ferrochelatase. You guys are probably like, dude, Zach, why the heck am I learning biochemistry? I'm trying to learn about anemia. I promise it'll come together, just give me a second. Protoporphyrin, when reacting with the ferrochelatase, uses a special component here, all right? So this enzyme is supposed to be right here. I'm gonna bring it closer here. And what this enzyme is supposed to do is it's supposed to take iron, which is gonna be brought to the bone marrow, and it helps to catalyze this step by actually pushing iron into the protoporphyrin. And so we're gonna push the iron into the protoporphyrin, and when we do that, we finally will make our molecule that we refer to as heme. All right, so this is our molecule, heme. And then what we'll do is we'll take that heme, combine it with the globin chains, and we got hemoglobin. So this is how we synthesize heme. The reason why I stress this is because it may be easier for you to remember how these three diseases cause an impairment in heme synthesis. Iron deficiency anemia is within the name. There is a decrease in total iron. If I have less iron, what's going to happen? Am I going to be able to convert iron with protoporphyrin and make the heme? No. So this step here, I'll represent this iron deficiency. I'll put like a Roman numeral 1 here. This part is being impeded, right? So this part here is just going to be, I just want you to remember here, we won't put the Roman numeral. Let's just put in this concept here, this process is actually being impeded. If we don't have enough iron, we're not going to be able to combine the iron with the protoporphyrin and we'll make less heme. All right, there's one thing. Sideroblastic anemia is there is a decrease in some of these enzymes. So maybe some of these enzymes aren't working. So there's either a decrease in the enzymes that are involved in this step, or there is an absence of these enzymes that are involved in these steps. And if I don't have these enzymes, so let's imagine I don't have these enzymes to be able to catalyze this process, will I be able to do these particular things? No. So this process will be impeded, this process will be impeded, and this process could also be impeded. So if I'm impeding these processes by not allowing these enzymes to be present or have enough of them, I won't be able to synthesize my heme, all right? That's the concept that I want you guys to understand. Now, the last one here is anemia of chronic disease. Anemia of chronic disease is a little bit weird, all right, especially in the later stages. So usually anemia of chronic disease, it can actually have a normal MCV, but then over time, so in the early stages, so we'll say early in this disease, the MCV is usually normal. So we call this normocytic anemia. But then over time, and I'll explain why, the MCV does drop in the later stages of this disease, all right? So it is really important to remember this concept right here, that most of the time for anemia of chronic disease, the patients have a normocytic anemia, but in the later stages of their disease, they do exhibit microcytic anemia. Let me explain how this happens. Some patient has chronic inflammation. That's usually the case. The chronic inflammation causes the release of a molecule. We'll go over this a little bit more later, but just a basic here is it releases a molecule called hepcidin. This is a molecule called hepcidin. It's released from the liver in response to inflammation. Hepcidin basically works on macrophages and works on your GIT. And we'll discuss these a little bit more later, the specifics, but it basically kind of inhibits these areas by blocking a special channel. And so you aren't able to release iron from the macrophages and you aren't able to absorb iron across the GIT. If I can't do that, what does this kind of look like? I kind of, in a way, over time, I decrease my iron levels. So I may decrease my total iron levels, and it'll kind of, in a way, look like iron deficiency and anemia. Iron deficiency anemia. So it's kind of in that same concept, except the mechanism has nothing to do with how the patient develops iron deficiency. In this case, it's an inflammatory process that's impeding absorption and impeding the release of iron from macrophages, so they sequester the iron. And so less iron is actually available to the actual tissues to go to the bone marrow. That's why I want you to understand that. So if there's an impediment in this process, there's not enough iron, or there's not enough of these enzymes that are working, right? That could be a problem. One last thing, and I have to talk about this, was ALA synthase. It's a very important enzyme. It's probably one of the most important enzymes in this step. It is heavily, heavily dependent upon a cofactor called vitamin B6. You need vitamin B6 to drive this enzyme. So it's a very important cofactor. If there is an absence of this enzyme, the ALA synthase won't work. And we'll talk about that a little bit later, okay? But to get the point across with this aspect of anemia, low hemoglobin, microcytic, low MCV, what's really happening in this process? You're either not making heme because of iron deficiency anemia, sideroblastic anemia, anemia of chronic disease. How do they do it? I'm either not absorbing it, I'm losing it, or I have a high demand and I don't have enough of it available for my bone marrow. All right? Here, I don't have the enzymes present or in enough amount to be able to synthesize the heme. So I either don't have the iron to combine to make heme, or I don't have the enzymes to be able to stimulate these processes to make heme. And then lastly, anemia of chronic disease in the later stages, the inflammation prevents iron from being available to be utilized by the bone marrow because of inflammation. All right, these are important points to remember. Now, that's the heme synthesis. We come to the next part, which is the globin. So we already know if we don't have heme, it's because of less iron, less enzymes, or inflammation that's not allowing for the enzymes to be readily, or allowing for enough iron to be readily available at the bone marrow. Now, decreased globin synthesis is you're losing the globin chains. You're not making them, or you're not making enough of them. And this comes down to two parts. So, you have globin synthesis can be alpha thalassemia and it can be beta thalassemia. And that's because when you look at globin, there's alpha chains and beta chains. If a patient has alpha thalassemia, there is some type of deletion usually on chromosome 16. And what happens is actually pretty straightforward. Depending upon the amount of deletions they have on those chromosomes, they will either make very little or no globin, alpha globin. So it could either be a decreased alpha globin or it could be no alpha globin. And so if I don't have enough of these globin chains, then what can I do? Can I make my hemoglobin? No. Because here's the point here. When we talk about hemoglobin, there's actually a couple different types. There's hemoglobin A, there's hemoglobin A2, and then there's hemoglobin F, right? Hemoglobin A is when you have the most abundant one, usually in adults. It's when you have 2 alpha and you have 2 beta. So what would happen to these patients with alpha thalassemia? Well, they won't have as much of these alpha chains. And so the beta chains will be the only thing that they have. The other one is hemoglobin A2. This one is usually 2 alpha and 2 delta, right? And so again, in this position, you would have less hemoglobin A2 because you won't have as much of the alpha chains. And then hemoglobin F is you have 2 alpha and 2 gamma. So this is the concept that I want you to understand here. When we talk about most of the hemoglobins, this makes most of the hemoglobin in adults. This is the most common in the fetus. And this is the smallest percentage despite being adult or fetus. All right? So if these patients are having an absence or deficiency in these globins, we'll talk about how this will affect their hemoglobin electrophoresis. Same concept. For beta thalassemia, they have not a deletion, it's more of a point mutation at the promoter region and splicing site on chromosome 11. And so in these, you could again have the same exact concept. You could either have a decreased amount of beta globin or you could have no beta globin. And we'll talk about those subtypes when we get there. But again, it's either a decreased beta globin or no beta globin. Now, again, think about how this would affect it. And this is the one that you likely get tested on the exam. And we'll talk about it a little bit more when we get there. But which one of these you have beta globin? Hemoglobin A. And so it's the only one. Alpha chains are pretty much in all of these. But beta globin is only in hemoglobin A. So what will happen? You'll have to bump these up to compensate for the decrease in this one. And that's actually really, really helpful. And we'll get to that when we talk about this later. So again, these are usually genetic, all right? These oftentimes, except for 1 or 2 cases in sideroblastic, are oftentimes acquired. And so these are important things. You'll see this more in the younger patient population, and you'll likely see these more in the older or adults kind of onset population. So now that we've kind of gone through this, We've generated our pathophysiological concept of what anemia is, what microcytic anemia is, what causes impairment in heme synthesis, what causes impairment in globin synthesis. Now let's go through each one of these and have a better understanding of what causes iron deficiency, what causes sideroblastic anemia, what causes anemia chronic disease, and what causes thalassemia, and what might be some really important high yield points or complications that can arise from these diseases. All right, so we'll move on to the next part, which is iron deficiency anemia. So we again know that this is a part of an impairment in heme synthesis. You don't have enough iron to combine with the protoporphyrin to be able to make heme. Less heme, less hemoglobin, that's how we get anemia. If the size of the red blood cell is less than 80, it's microcytic. How do patients develop iron deficiency in the first place? It's actually pretty straightforward, and you can kind of break it into these categories here. So it's either you're not taking in enough iron in your diet, or you're not absorbing the iron that you're actually taking into your diet, right? Or you're losing iron from your bloodstream, because again, iron is a very important component of hemoglobin, and so if you're losing blood, you're losing with it hemoglobin, which contains iron. And then lastly, if your body requires more iron that you actually are able to take in, then that could also create a kind of a functional iron deficiency, if you will. I'd say out of all of these two are going to be the most common though. So if we have a patient who, let's just say, they are a strict, like vegan, right? A strict vegan or vegetarian, they're not getting enough potential iron in their diet. And so if that's their problem, it's this point of their GIT that's being impaired, the ability to bring iron into the actual GIT to hopefully be absorbed. So this part is being impaired, and that is the reason why that there's less iron. So there's less being actually taken into the GIT to be absorbed, right? And so if I'm not bringing enough iron across my gullet, I'm not going to be absorbing enough iron into the bloodstream. And if I don't bring enough iron into the bloodstream, then again, if we go back to that process in heme, that's going to mean less heme, and that's going to lead to less hemoglobin. Right? So this is a pretty kind of straightforward process here if we think about this. Now, what I need us to think about here for the next part is what if it's a problem with the GIT? So what if it's not this part where you're having a good time, you're eating all the food that you need and you're getting enough iron in your diet. The problem is that it's this part that's being impeded. So it's some part right here that's being impeded. It's not this part, it's this part. What would that have to do with? This would be some type of decreased absorption. So it's either you're not taking it in, you're a strict vegan, or second, there's some other potential situation here where you're not absorbing the actual iron that you're taking in. And so in this potential scenario, what I'd be thinking about is I'd be thinking about a couple different causes, and I'd be looking for this in the vignette. I would look for things like, for example, do they have a history of celiac disease? So this is kind of a malabsorptive disease. So they would have some type of small intestinal disorder where there's inflammation, where there's destruction and loss of the villi, where they wouldn't be able to adequately absorb the iron. Another one is I'd be worrying about Crohn's disease. So inflammatory bowel disease, particularly the Crohn's type. This would also cause inflammation of the ileum or parts of the small intestine, which also play a role in absorption. Another one would be a Roux-en-Y gastric bypass or any kind of bariatric surgery. Even gastrectomies can also cause this as well. But I'd say RYGB would be the big one, because what you're doing is you're cutting off a part of the stomach and you're rerouting from that pouch now that the stomach, you're bypassing a part of the duodenum and going to a later part of the small intestine. So you're bypassing an area where you're supposed to be absorbing it, all right? So Roux-en-Y gastric bypass, inflammatory bowel disease, celiac disease, any kind of resection, really, you could even add that in as well. But I would say any kind of malabsorptive disorder really would be the reasons that you would not be absorbing the iron across the GIT. And if you don't do that, you don't get into the blood, you don't make enough heme and hemoglobin in the red bone marrow. So these are the things I want you guys to think about, all right? Now, the next component that I would also like to add on is what if you're having blood loss, right? So we see this actually a lot in patients who have heavy menstrual bleeding, all right? So patients who have heavy menstrual bleeding, you can actually lose a decent amount of iron within a day. And if you're losing more, then that's, again, going to put you into a deficient state. And so we would say oftentimes that patients who have very, very heavy menses would also be a very, very common cause here. Because what we're looking for is we're not looking for this to be something that's acute. So I'm not looking for a patient who has like postpartum hemorrhage, right? I'm looking for this to be more of something where it's a slow process, or it's kind of happening over a period of time. So it's happening kind of like maybe monthly in this particular scenario here. So with this, that's when you want to go looking. Is there any kind of like uterine fibroids, or is there anything that's kind of causing this heavy bleeding? Is there some type of hormonal issue that's going on? So heavy menses or abnormal uterine bleeding, we'll put abnormal uterine bleeding, would be a big thing to be thinking about, because this will definitely cause a lot of loss of iron, more than your usual amount within a day. All right. The other one that we tend to see a lot, and again, these have to be chronic slow bleeds, is I would say peptic ulcer disease. So if a patient develops like a small little ulcer where they're kind of just like not pumping or gushing blood into their small intestine or into their stomach and then into the small intestine, it's just little bits at a time where they're kind of have a small bleeding ulcer or a slow bleeding ulcer. That will cause that to be lost eventually into where? Into the stool, all right? And so that's another potential thing to be considering as well, is losing blood via the GIT. So we see this a lot in GI bleeds, right? So I'd say one would be peptic ulcer disease. So peptic ulcer disease, all right? Obviously with this, we see this a lot with H. pylori, all right? Another thing you can also see, with that being said, the decreased absorption, sometimes atrophic gastritis or any kind of gastritis can also affect this to some degree as well. But big thing is peptic ulcer disease for the slow bleeding, which can cause a loss of iron more than we lose in a day, all right? And then the other one, and I'd say this is a really high yield one to remember, let me get my brown marker here, is if a patient has colorectal cancer. So colorectal cancer can also cause slow bleeding as well. And so you would really, and they always bring this about in the vignettes, if you have a patient who has suspicion, right? So they're greater than 50 years of age, right? And they have iron deficiency anemia, ooh, you better be thinking about potentially colorectal cancer, right? And the reason why I'm mentioning these is if you have a patient who comes in, you eventually diagnose them with iron deficiency anemia, you have to figure out the cause. Look through their history. What's your diet look like? That may pick out the strict vegan. Also look to see, are they having any weight loss? Are they having any other nutrient deficiencies? Because oftentimes if patients are having malabsorptive syndromes, it's not just iron that they're losing, there may be other vitamins and other nutrients that they may have. So they may experience weight loss, right? And they may also have other nutrient deficiencies. For patients who come in, they're young and they're saying, I'm reporting that I'm having these heavy menstrual bleeding during my periods, that may tip you off. Another one who's coming in and saying, hey, it's not just heavy menses. For me, I'm having, maybe I'm having melena, right? Right? That may also point you out to say that. If for some reason they also have other signs of GI bleeding, you could think about that as well. But if a patient is saying, I'm having these kind of black tarry stools, that may trigger you. But it also may be kind of one of these patients who has features of peptic ulcer disease and we have a known diagnosis. Think about that. You may have to go do an EGD and a biopsy. Or colorectal cancer, that patient who's greater than 50 years of age and they have that kind of iron deficiency anemia, maybe with some other features that concerning for, colorectal cancer. So these are the things I really want you to be thinking about is, again, it's slow chronic bleeding in these potential forms, or it's you're not taking in enough through your diet, not as common, or you're not absorbing it, pretty common. So these are going to be the most common reasons. The last reason that you would potentially experience this is if a patient has a very high demand, way higher than other patients. And I'd say the most common reason, son of a gun, we would see this in is a patient who is pregnant. So during pregnancy, not only does the patient need enough iron for her to generate red blood cells, but she's also going to need enough iron for the development of the fetus. So during this time, that demand of iron is going to be extremely high. So I'm going to have to be delivering tons and tons of iron to the actual tissues for this baby, as well as for what? For the mother, to allow for all these processes that are dependent upon iron. If my intake is not up to that demand, I can develop a functional iron deficiency. So let's just say that my consumption of iron is not equaling, or there is a mismatch between these two. So there is less iron that's actually available and more iron being utilized. This will produce, in a way, a functional iron deficiency. So decreased available and then increased consumption. This will create that mismatch, if you will, kind of like angina, if you really think about it, right? So if you have a decreased supply and an increased consumption or demand, that'll create a mismatch and cause ischemia. And the same concept here, if I have less available and more being consumed, I'm not going to have enough iron in my bloodstream for me to be able to allow for this process. And then on top of that, go to my red bone marrow and make red blood cells. So think about this in patients who are pregnant. They may have very, very high iron demands, and you may have to increase their supplementation during that time frame. Okay? So iron deficiency anemia, we know, is these particular things that we have to be looking for in the clinical vignette. And then once we've diagnosed it, we may have to consider a more thorough workup. If I don't think it's a vegan thing, I may have to do some type of workup for celiacs. I may have to do a colonoscopy for IBD. I may have to actually consider that it could be from their post-bariatric surgery complications. I may have to do an EGD. I may have to do a colonoscopy. I may have to do an ultrasound or transvaginal ultrasound or pelvic ultrasound to look for reasons for heavy uterine bleeding. These are important things to consider. Now, when a patient has iron deficiency, and I'd say out of all the microcytic anemias, this is by far the most common one that you'll come in contact with, you have to be thinking, what are the ways that they may present? Oftentimes, most anemic patients present with a classic finding, which is usually conjunctival pallor, which we'll talk about, maybe some fatigue, potentially dyspnea, worst case scenario, they may have some angina. But these are common ones. And patients with iron deficiency anemia, they may have special characteristics that lay itself to that disease only. And some of these include, and I'll mention these, koilonychia. So this is basically when you have these spoon-shaped nails. This is what it would actually look like. The other thing is that these patients have a very high risk for what's called pica. And pica is basically this weird craving that these patients get for non-food substances like clay and dirt. It's really odd. So if you have a patient who's coming in and they have classic findings of anemia, plus they're eating like clay and dirt, that should really make you think about iron deficiency. The other one that I would say is going to be restless leg syndrome. We don't really know why. It maybe have something to do with the neurotransmitter process, but we know that iron deficiency anemia can also cause a presentation of restless leg syndrome. The thing that you really might see on the exam, and you may see it in this system or you may see it in the GI system, is that oftentimes this comes along in the vignette with Plummer-Vincent syndrome. So a patient has what we know as iron deficiency anemia. So we're going to say that they're coming in with iron deficiency anemia, or as I abbreviate it, IDA, plus two other features. And one is they may have these things called esophageal webs, right? So these esophageal webs. And the things with esophageal webs are these weird structures that can exist within the esophagus, and they can impede the movement of food and fluids through the esophagus. And what's a presentation of food being not able to get through the esophagus into the stomach? Dysphagia. And so oftentimes the presentation of esophageal webs is that they may present with dysphagia. So if a patient has these three characteristics, if you will, esophageal webs, dysphagia, and iron deficiency anemia, I would really be thinking that the patient could have, again, iron deficiency anemia. So these are important things to remember. And again, usually this is the presents as dysphagia, okay? So there's iron deficiency anemia in a nutshell. What I need to now move on to talk about is the sideroblastic anemia. So there's two different ways I like that you guys think about it. Again, you guys remember it was something to do with the enzymes. Iron deficiency, you just didn't have enough iron to combine with the protoporphyrin to make heme. In this situation, you don't have the enzymes present or enough of those enzymes to help to synthesize the heme. This could be genetic or it could be acquired. For genetic, you want to think about this. You'll see a patient who has a family history of anemia likely, but this is usually, in the scenario that we can see this is a X-linked defect. And what happens is in this X-linked defect, they have a decrease or absence of ALA synthase. So they have a decrease or absence of ALA synthase. So this is the really important thing here. If you guys remember, just a quick reminder, what was the enzyme that was present here in that cytoplasm that was really, really crucial? I told you it was probably one of the most important enzymes, ALA synthase. And that's why I mentioned it, because again, if you guys remember, we said that it takes glycine and it takes succinyl-CoA and basically combines these two and catalyzes this step to make a molecule called ALA, or amino levulonic acid, right? So that's the process this is supposed to stimulate. If I have a genetic defect where I don't make this enzyme, what's gonna happen? If I don't have this enzyme, can I stimulate this step? No. So then I don't make enough of the ALA. And then if you go back, remember there was another enzyme out here. It's not as crucial to this step now, but there was another enzyme here called ALA dehydratase. And again, this is just a nice quick reminder. The ALA dehydratase was then going to take the ALA and convert this into what was called what? Porphobilinogen. Porphobilinogen. And then we said through a series of steps which aren't really pertinent to us, it goes through a bunch of other steps and eventually gets converted into what's called protoporphyrin. So protoporphyrin, and then again, there's different types, but this is actually going to be protoporphyrin 9. Now, protoporphyrin, once we have this protoporphyrin 9, it's then supposed to be acted on by this enzyme called ferrochelatase. Now, ferrochelatase will then take the protoporphyrin, and again, what did I say it does? It combines it. So this ferrochelatase is supposed to combine the protoporphyrin with another guy who jumps into this process. Who is the guy that jumps into this process? The iron. So here's what I want you to remember. If we don't have this enzyme, we then will not be able to synthesize ALA. We won't be able to go through this process and make enough of this guy, which is our heme molecule. And if we don't make enough of this heme, boy, we ain't gonna make enough of this hemoglobin, right? So now, here's what I want you to think about. In acquired causes, there's some other issues that come along. This is usually, the big one that I like to say to think about, is B6 deficiency. So this could be a true vitamin B6 deficiency, right? The reason why is vitamin B6 is an integral component to ALA synthase. So if a patient has B6 deficiency, if they have less B6 in their body, guess what? That less B6 leads to less activity of the ALA synthase. If there's less activity of the ALA synthase, can you stimulate this process? No. Can you make ALA? Can you go and make heme? No. Now, B6 deficiency, I think it is actually really important to remember that this could actually be from a dietary aspect, but also one big thing to be thinking about here is definitely think about this in patients who are taking a drug. We see this sometimes in the exam. They're on isoniazid, right? Or this could be dietary. So this could be dietary, or this could be from isoniazid toxicity, which we use to treat patients who have tuberculosis. So look at the vignette for a patient who is being treated with tuberculosis for isoniazid and all of a sudden develops sideroblastic anemia. The other ones are all things that cause mitochondrial toxicity. So mitochondrial toxicity. And as we see here, the ALA synthase is located in the mitochondria, the ferrochelatase is located in the mitochondria. These are key things that are involved in heme synthesis. If we cause toxicity to the mitochondria, can we make heme? No. So what are some things that cause this? Alcohol. What else? Chloramphenicol. Chloramphenicol. What else? We also see this sometimes in other drugs as well. But I'd say that these are going to be some really two big ones here that we definitely can't be forgetting about. So if a patient is having alcohol abuse or chloramphenicol use, this is something that I would definitely want you guys to be considering as a potential cause of mitochondrial toxicity, which then you lose these enzymes. Okay, from this, we have now generated a concept here of what leads to sideroblastic anemia. We know it's an impairment of these enzymes, but there's one more. This is actually pretty high yield. This last one here, it can cause mitochondrial toxicity. The problem is though, is that this one affects a couple different enzymes, and this is called lead poisoning. Now, Lead poisoning, sometimes you may hear people get really bent out of shape about this because oftentimes we say, oh, it's not really a part of sideroblastic anemia, it's its own thing. And it kind of is, but we like to combine the two. I like to see lead poisoning being a part of the sideroblastic anemia. What happens with lead poisoning is that this inhibits two enzymes. One is it inhibits the ferrochelatase. So it's going to inhibit the ferrochelatase. And if you guys remember, what does the ferrochelatase do? If I inhibit this enzyme, can I stimulate the synthesis of heme or incorporating the protoporphyrin and the iron together? No. So this step is impeded. That's one mechanism. The other one is ALA dehydratase. Can I help to convert the ALA into porphobilinogen? No, that's inhibited. So that's the reason why I'm mentioning all these steps, is because it's supposed to inhibit separate enzymes in this process which you may be tested on. This may be more of your USMLE step 1 exams, but again, you could see it in the step 2. But inhibiting that or the ALA dehydratase is oftentimes the things that you could see as the effect here in lead poisoning. Now, sideroblastic anemia, what do I again want to leave you with? Genetic, look for a family history. This could be a deficient ALA synthase enzyme, all right? Or acquired. Look for in the history dietary factors that can cause B6 deficiency or a patient who is taking isoniazid for tuberculosis. Also look through their history of medications. Are they taking chloramphenicol? Or on top of that, do they have any history of chronic alcohol use? And then lastly, we'll talk about some very high yield points with lead poisoning. Lead poisoning is a very specific thing that you'll likely see on the vignette. Let's talk about what that would be. So, sideroblastic anemia, the way these patients present is like any anemic patient. So they can present with pallor, they can present with fatigue, they can present with dyspnea, and again, depending upon the severity, they can present with hyperdynamic states. But lead poisoning gives a very specific picture, just like iron deficiency anemia with Plummer-Vinson syndrome and Koilonikia and pica. This has a very specific presentation. So lead poisoning, think about a young child who is eating like lead chip paint in the garage for whatever reason, and they come in and they present with a very specific set of symptoms. We say lead to remember the mnemonic here. So it's lead lines on the gums. Sometimes they call this Burton's lines. It looks like this. The next thing is they can come in with encephalopathy. So you're like, okay, what the heck does encephalopathy look like? They can come in confused, they can come in very agitated, irritated, failure to thrive, etc. The next thing is they can come in with abdominal colic. So abdominal colic is they can come in with severe abdominal pain. And then lastly is a D for drop. So they could have a drop of their wrist or more commonly the foot. So these are things that you want to be thinking about in these patients. Is a patient who comes in, has anemia, they're a young child, they have lead lines, that's the big one. They have encephalopathy, confusion, agitated, failure to thrive, abdominal pain, and then wrist drop or foot drop. The other thing which is really important with lead poisoning is most patients who have sideroblastic anemia, they can have what's called basophilic stippling. But this stippling is very important in sideroblastic anemia because they don't cause these ring sideroblasts. So for lead poisoning, when you look at what's called their peripheral blood smear, so when you look at their blood smear, whenever you inhibit ferrochelatase and you inhibit ALA dehydratase, you can't incorporate the iron into the heme. And what happens is the iron kind of builds up in the mitochondria, around the nucleus, and what happens is you inhibit other aspects, which is like ribosome synthesis. And so what happens is you get a lot of this like mRNA kind of accumulation here inside of these like kind of not necessarily mature red blood cells. And so this is called basophilic stippling. And this is a very important thing that we commonly see on patients who have lead poisoning or sideroblastic anemia. And that's why sometimes we combine them. But again, lead poisoning, this presentation, plus the combination of the basophilic stippling that's present on blood smear. What would that look like? It would kind of look like this. So now with that being said, we now have an idea of all the causes and a little bit more kind of like linking together the sideroblastic anemia as a cause of microcytic anemia. Let's move to the next one, which is anemia of chronic disease. All right, so iron deficiency anemia, kaput. We done killed it, right? Capiche. Sideroblastic anemia, we put that thing in the ground, we're good. The next one is anemia of chronic disease. What we have to understand with this one is, again, it's more likely to be a normocytic anemia in the early stages. In the later stages of the disease, it can start to progress to iron deficiency anemia. Again, quick recap of that, because again, why not? In patients who have chronic inflammation, when you have lots of inflammation, what normally happens is your body responds, and we'll talk about what are the reasons why these patients have chronic inflammation. This can cause an uptick in what's called interleukin-1, tumor necrotic factor alpha, interleukin-6 is another one. All these poppies can be super elevated. When these poppies are elevated, right, what they do is they got receptors. They got receptors on the liver. And the liver says, all right, there's definitely some inflammation going on. What I need to do is kind of prepare for this. And usually the liver is kind of smart and it says, okay, if there's a lot of inflammation, sometimes we think of inflammation in the scenario of like infection. So there's like a bacterial pathogen of some sort in the body and it's wreaking havoc. So what the liver does is it's pretty smart, and it releases a molecule called hepcidin in higher quantities, right? And this hepcidin, whenever it's released in these higher amounts, what it does is it goes and tells the macrophages. There's a protein on the macrophages and it's called ferroportin because it's very important. I know that was pretty corny, but whatever. Hepcidin goes to this channel and it shuts that ferroportin channel down on the macrophages. And it goes to the ferroportin channel that's present on the enterocytes and it shuts that channel down. The point of these channels is that normally the macrophage can kind of spit out a little bit of iron out of these cells and kind of, because it can actually break down red blood cells, macrophages, right? And we can help to recycle the iron, send it back to the red bone marrow to make more red blood cells. But what if I shut that process down because of high hepcidin levels? Can I liberate the iron into the bloodstream and then the iron go to the red bone marrow? No. And so the problem with this is that I end up getting less iron present inside of my bloodstream that's available to go to my red bone marrow. So there's one problem. The other thing is that if I have iron in my GIT that I'm actually eating through my diet and I want to absorb that iron, guess what? That part's being impeded. And then again, I get less of the iron into the bloodstream. Less of the iron into the bloodstream means I have less iron to go to the bone marrow. So less iron that will be delivered to the bone marrow. And the problem with that is if I don't have enough of this iron going to the bone marrow, what's going to happen? My ability to incorporate this iron into heme is going to be reduced. Can I make red blood cells? No. And so that's what usually happens to these patients, is they kind of exhibit like somewhat of a functional iron deficiency. And again, this is in the later stages. Here's what you have to remember. One of the other really cool things about this disease is whenever you have lots of inflammation, this is actually kind of a diagnostic helpful thing, is not only does the liver release hepcidin, it releases another molecule called ferritin. And this is actually kind of helpful because this is one of the only, one of the real big diseases here that whenever there's inflammation, ferritin levels tend to be elevated. And we'll see how this is diagnostically helpful, because in patients who have microcytic anemia, the first test that we usually order is we check an iron panel. And we check the iron panel, we look to see if the iron is low, normal, or elevated. In patients who have low iron levels, we then have two differentials, anemia of chronic disease and iron deficiency anemia. We then next look at the ferritin level. If the ferritin is elevated, it's more likely to be anemia of chronic disease. That isn't always perfect, but it's more likely. And then the last thing we look at is the TIBC and the transferrin saturation. But again, this is a really helpful diagnostic tool, that anemia of chronic disease, they usually have chronically elevated ferritin levels, which you don't see that in patients who have just iron deficiency anemia with nothing else going on, like inflammatory-wise. All right? So this is the big thing to remember. Now, the next component here is you have to ask yourself the question, just like we asked with sideroblastic anemia, we know that there was an impairment in the heme enzymes. One is because you have a genetic defect where you don't make the enzyme, or you have drugs or a lack of B6 to be able to allow for those enzymes to work, or you're causing toxicity to the mitochondria where the enzymes are. Either way, same concept, what's causing this inflammation, which is causing the liver to upregulate the hepcidin. And it's actually pretty straightforward. The most common causes are going to be autoimmune diseases like rheumatoid arthritis and SLE. So if you have a patient who has also concomitant joint pain, that would also be something to definitely be thinking about, especially if like this classic malar rash, right? And you can check their antibody levels, the ANA, right? The double-stranded DNA anti-Smith, and you can check rheumatoid factor as well for RA. The other thing though is malignancy. So malignancy is going to be a big one, and the two that I would say that we often tend to see this a lot with is going to be lung cancer. So we can definitely see this in lung cancer, and we can also see this in colorectal cancer. So definitely be thinking about these patients having, again, these types of processes if they have like a solid organ kind of tumor. The last thing I want to briefly talk about, I don't want to go too ham on it, is that sometimes patients will say, oh, what about anemia of CKD? That's a chronic disease. Sure is. The mechanism is a little bit more different. And for anemia of CKD, their problem is nothing to do with hepcidin, really, it's more erythropoietin. So in patients who have CKD, they don't make enough erythropoietin. If they don't make enough erythropoietin, that doesn't tell the red bone marrow to make enough red blood cells. Oftentimes, anemia of CKD is oftentimes mostly normocytic. Very rarely will it be microcytic, all right? It can, but it's much less common. Anemia chronic disease, it's usually normocytic, but in the later stages, it can progress to microcytic. So again, those are really important points to remember. So now that we've gotten anemia chronic disease done, again, it's a matter of knowing it's inflammation that's causing the uptick in hepcidin that's causing this process. And again, don't forget, ferritin levels usually elevated in these. That's a big thing to remember. And again, later stages, look for a patient who has progression of normocytic to microcytic, usually in this process. All right, so moving to the last one, which is thalassemia. So with thalassemia, the thing I want you to remember, right, iron deficiency anemia, again, you're gonna look at the vignette. It's gonna give you some inclination that there's strict veganism that's going on. They have some type of malabsorptive syndrome going on. They may have some chronic blood loss, which is evident based upon what they're speaking of. I'm having heavy menses, or I'm having, melena, those kind of dark tarry stools. And then in sideroblastic anemia, again, you're going to be kind of looking through the history, looking to see if there is a family history. You might think about the X-linked process, looking for any drugs, isoniazid use in tuberculosis, which may kind of lead you to B6 deficiency or dietary factors. Again, looking at alcohol use and other drugs that could be causing this, and that lead poisoning. Again, with that classic lead kind of mnemonic presentation. With anemia chronic disease, you're looking for a patient who has chronic diseases, and they started off with a normocytic and they kind of branched over to the microcytic. And again, look at that ferritin level. That might be a little bit more helpful in the diagnostic cues. Thalassemia is going to be a very young patient, all right, especially if they're going to be presenting. Oftentimes, if they're kind of the minor deletions, they're not too bad. They may be silent carriers, or they may have a very mild disease or almost no disease. It's more of like whenever they have very bad deletions that they present with very severe presentations, and usually at younger ages. So family history of anemia, and then on top of that, frequent history of transfusions. That's what you'll look for in the vignette. But with thalassemia, there's two types. We already talked about this. There's either an absence or deficiency of alpha globin, or an absence or deficiency of beta globin. Depending upon that term, deficiency or absence determines the type or subtype of thalassemia that you have in that grouping. For example, let's say that we have all these alpha globin genes. If I have a deletion and just one, then that's a specific type. If I have it in 2, that's a specific type. If I have 3 gene deletions, or if I have 4 gene deletions, this will tell us the subtype of alpha thalassemia. So one gene deletion fits what's called alpha thalassemia minima. Oftentimes, this patient is just a silent carrier. So you just, their offspring is the higher risk. That's the thing that you want to watch out for. So there's one deletion, all right? The next one is going to be alpha thalassemia minor. These have 2 deletions, but we oftentimes use some terminology which can come up in your MCQs as just a simple base question, or step 1, but you could see it. There is cis alpha thalassemia minor, and then I'm going to continue off of that. There's going to be trans alpha thalassemia minor. So these are both 2 deletions on the alpha gene, right? And the chromosome, again, this would be chromosome 16 as we talked about. Now for this, Again, these patients, they can present with more of like the mild disease. So it could be very mild or no anemia. So very no anemia or any symptoms of anemia, or it could be very mild anemia. So oftentimes these patients don't present too significantly bad. You may see a very, very low MCV and some mild anemia, but nothing crazy. It's when you get into these two that we start to see the problems. As we get to 3 deletions on the chromosome 16 alpha globin genes, that's when we start to see some issues. And this is where we see one called hemoglobin H disease, which is for the 3 deletions. These patients oftentimes present with severe anemia. All right, they present with severe anemia, and they present very young. And we'll talk about what that presentation looks like in a little bit. The worst case scenario is that's the one where patients usually don't make it. Because this is a genetic problem, the next one is called, we call it BARTS, or we call this hydrops fetalis. So this one is actually all the alpha globin chains are deleted. All right, so in this particular scenario, usually what happens is this is severe intrauterine hypoxia. So they have such severe anemia, and this anemia is so severe that it can actually cause very little oxygen delivery to the fetus. All right, and so this can cause intrauterine hypoxia. So intrauterine hypoxia. The problem with this is if you have enough severe intrauterine hypoxia, you can actually cause fetal demise. And so oftentimes this will lead to intrauterine death, so fetal demise. So oftentimes these patients don't make it. If they do, they could present with hepatosplenomegaly and congestive heart failure features. But again, usually these patients don't make it past the delivery point. All right? So this is why I want you guys to understand alpha thalassemia, yes, it is a deletion in the alpha globin gene on chromosome number 16, but the amount of genes that are deleted based upon the chromosomes, that determines the presentation. If it's 1, silent carrier. 2, that one may present with no anemia or very mild anemia. 3, you got pretty severe anemia, hemoglobin H disease. We'll talk about what that looks like. And the last one, 4, usually not compatible with life, fetal demise, and this is usually going to cause hydrops fetalis. All right? That's a really important thing to remember. On the other side is beta thalassemia. So beta thalassemia, you either have, let's say there's 2 ways of looking at it. You can either have decreased or absent a beta globin gene, and usually this is a point mutation. So this one's a little bit different from this one's a deletion. This is usually a point mutation, usually at the promoter region of the gene or the splicing site. And so this leads to kind of an abnormal reading of the mRNA. And so that's the problem with this one. So usually this is just going to be a decreased or absent of one gene, right? And so this is usually called beta thalassemia minor. Oftentimes, just like alpha thalassemia minima, this is a silent carrier. You'll never know you have the disease, but the offspring are a little bit more high risk for this potential scenario here. All right. If there is a decreased production of 2, it has to be 2. Again, it has to be decreased production. So I'm going to write this one down. Let's say that there is a point mutation, but this point mutation leads to a decreased production. And this one, it's either decreased or absent. Doesn't matter. For this one, it has to be decreased production on 2 of the genes, right? 2 of the beta globin genes of beta globin. This will present as beta thalassemia intermedia. So this can cause it can cause no anemia, or it can cause very mild anemia. So it's, again, kind of similar to alpha thalassemia minor. All right, this is called beta thalassemia intermedia. All right. The last one is the worst case scenario. This one is called beta, don't know why I'm writing this out, and I did all these with abbreviation there. The beta thalassemia major, this is you have, again, in this potential scenario, you have a absent. So you have a point mutation in both of the beta globin chains where you don't produce any of that protein. So there is an absence. So we're going to put no beta globin, no production of beta globin. So you can see here why this would be the more severe type. So in this one, this is a point mutation that leads to no production of beta globin. And this will produce very severe anemia. This is a lot of stuff, right? The point that I want to get across to you guys is that usually if there's just one, it's silent, nothing happens. If there's two for alpha thalassemia minor, okay, 2 deletions, it could be a very mild disease. Probably not something that you'll probably see on the vignette too likely. Again, here for beta thalassemia intermediate, there is a decreased production of the beta globin because of a mutation on 2 of the beta globin chains. All right. Again, mild. But when you get to the 3 here, or absence of the production of beta globin chain on this one, you get severe disease. So these are the ones that you're more likely to see on the exam. This one, the baby usually unfortunately doesn't make it. All right. One other question that you could potentially see on the exam, again, when I talked about this cis and trans, cis is you're having a deletion that's on the same arms of that chromosome 16 or opposite arms of chromosome 16. They may test you on which epidemiological kind of population you could see this in. And I like to think cis, I promise I'm not trying to be like weird or racist or anything like that, but I think C China. So cis China. So I think about Asian population. This is just an easy way for me to remember this, is the Asian population. This is more common in. And then T, I think of Tanzania. So I think about the African population. So again, I think about African population. So that might be something that you could get a basic MCQ question on, but again, nothing absolutely insane. So now that we kind of got an idea that the most important ones to take away from this is going to be the hemoglobin H disease, because it will present with the severe anemia because this is a deletion in 3 of the alpha globin chains. And beta thalassemia major is the one that you'll see for the beta thalassemia camp because this is going to be a mutation in both of the beta globin genes that leads to a absent or no production of the beta globin. These are going to be the most likely presentations. So we have to know what this severe anemia looks like, right? So let's talk about that. So again, patients who have anemia, they'll present with conjunctival pallor, fatigue, dyspnea, maybe angina if they have underlying coronary artery disease. Could present in hyperdynamic states if it's a really severe anemia. But they may have very specific clues that link it to thalassemia. For hemoglobin H disease, the process here is that there is a decreased amount of alpha globin, right? So decreased alpha globin, because again, this is a type of alpha thalassemia for hemoglobin H disease, 3 deletions. So because of that, what happens is your body has to do something, right? And it has to try its best to do something with these other globin chains that are kind of hanging around. And so unfortunately, the other kind of beta globins, they don't have any alpha globin to kind of connect with to make hemoglobin. And so what happens is you get these beta globin tetramers that start to form. It's all these beta globin chains that are kind of just sitting around together, and they kind of link up. And they form these little tetramers, and the problem with these little guys is that they kind of can cause these weird inclusion bodies in the red blood cells. So if you kind of look at the red blood cells here, you'll notice that these patients have these like weird inclusion bodies. Problem with these inclusion bodies is that our macrophages don't really like them. They kind of appears as foreign, right? So these inclusions can appear foreign. And our macrophages will actually destroy these. And when they destroy these, because these little beta tetramers form, it'll lead to hemolysis, right? So this will trigger a process called hemolysis by macrophages. And whenever you bust open these red blood cells, right, what happens is in hemolysis is that you release out something called LDH. right? And LDH tends to be very elevated in patients who have hemolysis. So that's one thing that can tell us about a clue that there is hemolysis going on in hemoglobin H disease. The other thing is it releases hemoglobin, because that's the main component. Now the hemoglobin, we don't want this puppy just running around by itself. That's a bad thing. That's a scavenger of nitric oxide, a bunch of problems that this can cause. It can get into the urine and cause hemoglobinuria and hemosideриnuria. But what we try to do with the hemoglobin is our liver makes a protein called haptoglobin. And haptoglobin, we measure this based upon it like not being bound to anything. So what happens is hemoglobin, if there's a lot of this hemoglobin, the haptoglobin will actually try and bind to the hemoglobin. It'll try to combine with it and make a complex, right? Which is containing the haptoglobin and hemoglobin. So what happens to the free haptoglobin levels? As a result of this reaction, it goes down. And so because of this, the haptoglobin levels, because you increase the amount of this complex that you're making, right? This results in you consuming the haptoglobin. And so your haptoglobin levels do what? They tend to deplete. And so this is one thing that we actually tend to look for in these patients who have hemoglobin H disease for thalassemia, is we look for evidence of hemolysis. So hemoglobinuria, hemosideриnuria, decreased haptoglobin, increased LDH. The reason why? The beta tetramers that are forming because you don't have enough alpha globin to bind with the beta globin. So it binds with itself. Now, the other thing is that these inclusions that are forming in the red blood cells, right? You cause hemolysis, right? Because of that. The macrophages notice that. Problem is when you cause hemolysis, you're already struggling to make red blood cells because you don't have all the globin. So already there's going to be a patient having anemia. On top of that, the hemolysis worsens the anemia. And that worsening of anemia, then guess what it does? It kind of goes back to the primitive states of our body. And this anemia says, hey, liver, spleen, can you help me, bro? Because I'm struggling to make enough red blood cells. And so this undergoes a process called extramedullary hematopoiesis. And what this is extramedullary hematopoiesis is a process where your liver and your spleen try to help make red blood cells. And so that's what it's going to try and do, is it'll try its best to be able to make more red blood cells. Because it does have that slight capability, but it's primarily our red bone marrow that's trying to do that. Problem is when you increase extramedullary hematopoiesis, you make the liver and the spleen do more work. They have to get bigger to do these jobs. And so this can cause hepatomegaly, and it can also cause splenomegaly. And so these patients can experience an enlarged liver, which you call hepatomegaly, and they can also experience splenomegaly, which is an enlargement of the spleen. These may be found on palpation, or they may be found on imaging. But if a patient comes in with evidence of hemolysis via these labs, hepatosplenomegaly, and you then say, okay, they have a family history, they've had a history of frequent transfusions, you should be thinking about hemoglobin H disease or potentially beta thalassemia major. Only way to truly tell is to get a hemoglobin electrophoresis, and I'll explain what that would look like later. But how could I also think, oh, this maybe leans more to the beta thalassemia camp than it does to the alpha thalassemia camp? With beta thalassemia major, there is a deficiency, absence of the beta globin. All right, so now there is a deficiency in this case, the beta globin, or absence of, I should say. I should actually be more specific. In this case, there is an absence of the beta globin. All right, in that scenario, you got a lot of these free alpha globins just hanging around. I'm just hanging around. And so because I got a lot of these alpha globins that are just hanging around, they're like, well, bro, we're not gonna just chill. We're gonna combine together and try to do our best to make a hemoglobin. Problem is, when these guys link up, it's the same kind of process. They make these tetramers, and these things are not good. Guess what they do? They get into these red blood cells, and they make these inclusions. These inclusions are sensed by macrophages. The macrophages say, bro, not around here, partner, not around here. And whenever these inclusions are sensed, these Macrophages rip up the red blood cells, and we already know this process. If I undergo hemolysis, what's going to be elevated? LDH. If I also release hemoglobin, because that's the other guy, what's going to happen to the other proteins? So I'll release hemoglobin. Make room for this guy here. I'm going to release the hemoglobin. But who's going to bind the hemoglobin and then decrease in value? Because he's binding with him. The haptoglobin, right? And so remember I told you I'll make a complex here of the hemoglobin and haptoglobin, right? But the haptoglobin is going to be the one that decreases as a result. The free haptoglobin. Remember we talked about this? So this is going to spill out. It's going to be high in the blood. This is going to spill out and be high in the urine. This will then combine with him to make more of the complex, but you'll have less free haptoglobin as a result of him being consumed by binding up that hemoglobin. All right? So that's the big things here. So you'll have a similar process. Only thing that's different is just the type of tetramers that are being formed. Same thing. You have anemia. You're already struggling to make red blood cells because you're not having enough of the beta globin to form proper hemoglobin. And then on top of that, you're hemolyzing your red blood cells. So your anemia is getting even worse. So what happens here, my friends? The same kind of concept. I'm going to go over to the liver. I'm going to go over to the spleen. And I'm going to tell them, hey, can you please help me? Can you increase the extramedullary hematopoiesis? And that's what it does. Just to make these arrows not too bad, let's actually bring these over here. Just so that we're not getting too confused. So again, both of these processes, both of them, are stimulating the liver and stimulating the spleen to make more red blood cells. Problem is, causes them to get bigger. The only thing that's a little bit different is that the severe anemia also signals the bone marrow. And then the bone marrow says, oh geez, I really got to get to work and try to help you guys out and make more red blood cells. And so what the bone marrow does is it kind of goes on hyperdrive. And when it goes on hyperdrive, it tries to expand to make more room for the red blood cells that it's going to try to produce. All right? And so it causes a bone marrow expansion. Now you're probably like, okay, well, what does that have to do with anything? Problem is the bones that actually are affected are a part of the skull and the face. And so this causes these like unfortunate craniofacial abnormalities in these patients. And it kind of looks like a chipmunk face. They get a lot of like changes in their overall anatomy. And then on top of that, their bone, like when you look at it on x-ray, they have this like weird like crew cut appearance where you can literally see it looks like they have like hair on top of their bone because of this bone marrow expansion. So that's another thing is that they can develop what we call an x-ray, a crew cut appearance on skull x-ray. They can develop a chipmunk facies as well. So if you see a patient who has crew cut appearance on their x-ray, skull x-ray, and a chipmunk facies with hemolysis, hepatosplenomegaly, family history of anemia with frequent transfusions, you definitely want to be thinking about beta thalassemia major, and you can confirm that with the hemoglobin electrophoresis. Now you may be saying, Zach, wouldn't this also cause this? It can, but it's less common. And again, I think it also helps with differentiating these two based upon clinical features in the vignette. Hemoglobin H, less likely to cause bone marrow expansion and the craniofacial abnormalities. Beta thalassemia major, more likely to cause the bone marrow expansion and the craniofacial abnormalities. Okay. So at this point, my friends, we have really talked about all the different types of microcytic anemia. What I want to do now is talk really quickly about what are some classic findings that we can see in these patients, and then I can combine those classic findings with specific findings of the disease. And then what we can do is put it all together and taking a diagnostic approach. All right, my friends, so we're going to talk about the classic findings of anemia. So what could they be? Now, in a patient who has anemia, you want to think about this, especially if a patient's presenting with chronic fatigue. So if they're having chronic anemia going on, this is definitely a likely cause. The other thing that you could see it in is dyspnea. You could see them presenting with shortness of breath or angina, chest pain. But again, I would work those up accordingly. If a patient comes in with dyspnea and, or angina, I'm not going to be thinking, oh, it's anemia. No, I'm going to work them up for like acute coronary syndrome, working them up for some other kind of pulmonary complication that they have going on, potentially. And then if I happen to meander upon anemia as the potential etiology, great. But When a patient has anemia, the concept behind these three are pretty much the same, in that you have anemia, right? So if you have a patient who has anemia, when you think about this, the anemia factor is there's a decrease in red blood cell mass. That means there's less hemoglobin. Less hemoglobin, what does hemoglobin do? Carries oxygen. If you have less hemoglobin, you have less oxygen carrying capacity. So there's a decrease in the O2 carrying capacity. So your ability to deliver oxygen to the tissues is reduced. So this anemia leads to a decreased oxygen carrying capacity. If there is a decrease in oxygen carrying capacity, your ability for this red blood cell to meander through the bloodstream and drop off oxygen is going to be reduced. If that happens, when tissues aren't getting enough oxygen, they start to experience a tissue ischemia. And tissue ischemia, again, depending upon the type of tissue, can present differently. So they may present with just generalized fatigue, right? They may present with dyspnea. And then worst case scenario, sometimes they can present with angina. The concept behind angina is actually kind of cool because if you think about this, a patient who has angina, they probably have underlying coronary artery disease. So if you have underlying coronary artery disease, think about this. Let's say here I have the blood vessel, right? And then in that blood vessel, I have this plaque, right? And then let's just say, for example, here's my myocardium. So here's my myocardium. If I have my myocardium, what do I know here? Well, I know that if they have this plaque, that's kind of, let's say, and I'll use this orange here to represent it. But let's say here, I have this plaque that's kind of occluding the coronary artery. If it's occluding the coronary artery, that's going to cause a reduction in oxygen supply. So now, already in a patient who has CAD, there is a decrease in O2 supply because of luminal narrowing, right? So if a patient has coronary artery disease, you already have a decreased supply of oxygen. Now, because of this plaque, right? So they already have a decreased O2 supply because of this plaque. If you now throw anemia into the mix, you're decreasing the oxygen carrying capacity even more, you're worsening the myocardial ischemia, and they can start to experience chest pain. So what that could do is if you add the anemia factor in here, now adding the anemia could stimulate an increase in their angina. And I think that's kind of important to remember, all right? Now, the next component here is pallor. Pallor is actually kind of interesting too because again, it's the same concept here. If you have anemia, you have less hemoglobin, right? Less hemoglobin means that you have less reddish hue to the actual blood. So if you have less hemoglobin, you'll have a decrease in the reddish hue to hemoglobin, right? And especially to your red blood cells. If you lose that reddish hue, hemoglobin is really going to give a lot of the color to your skin, right? And so if there's a decrease in this reddish hue of your hemoglobin and the red blood cells accordingly, what happens is the blood that's moving like nearby potential membranes can have less of that color to the skin. And so what this can do is this can give a decreased reddish color or reddish hue to mucous membranes. And what are these mucous membranes or the skin? So sometimes these patients can have kind of a pallor to their conjunctival membranes. That's a really, really common one. And on the palmar creases of their hands sometimes, those can also be kind of a little bit of a pallor like color. So look for that. And then I would also be looking out for any kind of potential pallor to any skin creases as well. So fatigue and pallor are really, really big ones. Think about dyspnea and angina as well. Lastly, in these patients, sometimes what can happen is they run the risk of a hyperdynamic state. The last scenario here, which we can see with these patients, is a hyperdynamic state. The concept behind this is, again, the same. And that one, top one, decreased oxygen carrying capacity. Second one, decreased reddish hue because you don't have as much hemoglobin running through your bloodstream to your skin and other types of mucous membranes. This one, if a patient has anemia, again, they're going to have a decreased oxygen carrying capacity. And depending upon the severity of the anemia and the acuity of it sometimes as well, what can happen here is if you have a decrease in oxygen carrying capacity, this can lead to less oxygen delivery to the tissues, right? And sometimes this can get picked up. This can stimulate these chemoreceptors, which are found sometimes around the carotids, right? So you have the carotid bodies, right? These carotid bodies tend to pick up this low oxygen carrying capacity. So if there is some degree of even a little bit of hypoxia or hypoxemia from the low oxygen carrying capacity, this could stimulate the chemoreceptors, right? So you could stimulate these chemoreceptors that are kind of located around that carotid area. Now, if you do that, you'll activate some of these cranial nerves that you have that are kind of supplied by this, especially like the glossopharyngeal nerve. And this can send signals, right, all the way to your brainstem, especially in the medulla. And in the medulla, there's going to be all these like different centers. And I'd say the big one is like the cardiac acceleratory center. Now, when this cardiac acceleratory center is activated, it'll send signals down, which will be kind of a part of our sympathetic nervous system, and the sympathetic nervous system will become hyperactive. So there will be an increase in the sympathetic nervous system activity as a result of these chemoreceptors being stimulated. So if these are stimulated, it'll send signals down these nerves to the brainstem, activate the sympathetic nervous system, and send these signals out to your heart. What it will do is you'll release lots of norepinephrine. When I release lots of norepinephrine, this acts on the cardiac tissue. When it acts on the cardiac tissue, it can act on the nodal system, and it can act on the contractile system. What's the end result? Well, if it acts on the nodal system, it can increase the patient's heart rate. And if I increase the rate of conduction, or I increase the pacemaker kind of setting, if I increase the heart rate, these patients can start to develop what? A heart rate that's a little bit too fast, especially greater than 100 beats per minute. What's that called? Tachycardia. So tachycardia is a pretty common one. And sometimes a manifestation of tachycardia is palpitation. So watch out for that as well. If the patient's coming in, they're saying, man, I'm having pretty frequent palpitations. This could also be the result of that. All right. The next concept here is it's going to increase the contractility. So we're going to stimulate our nodal system by increasing the heart rate, or we're going to stimulate the contractile myocardial cells to contract more intensely. If they contract more intensely, I will increase my stroke volume. And then on top of that, when you increase stroke volume, what does that increase? It increases cardiac output. If I increase my cardiac output, the problem with this is I'm going to be pumping a lot more blood out of my heart. When I pump large volumes of blood out of my heart at a faster rate, sometimes these will cause these patients to present very interestingly. There's a lot of blood that's flushing into the arteries. And so what happens is you get like these large bounding pulses that can sometimes be present. So that could be a thing to potentially think about. Could be these bounding pulses. The other concept here is that these patients also have a lot of blood flow moving across the aortic valves, especially during systole. And because of that, they can have these pretty large, or I would say systolic murmurs. And so these could be heard during systole. They're usually not high grade, they're usually low grade sounding, and they're not high intensities, but you will be able to sometimes pick up these systolic flow murmurs. The worst case scenario that I would say that there is something that should be considered is if the anemia is severe enough, and I'm talking like really bad and it's chronic and it's ongoing, sometimes what can happen is you can really cause the heart to have to go into overdrive. And so you're making the heart have to work really, really hard and push a lot of blood out. So their ejection fraction sometimes cranks up. Sometimes it can be like really high, greater than 65%. And so in these scenarios, you're having the heart work really, really hard, and then the tissues aren't getting as much oxygen as they need. And so there is a mismatch, and what can happen is this can create a high output cardiac failure. And so that would be the worst case scenario, and it is something to potentially consider, is a high output heart failure. This is usually the worst case scenario, and I would say that you would see this in the most severe chronic anemia as a potential presentation. But take away from this, again, big points here. Patients who come in with anemia, fatigue, pallor, as well as tachycardia and maybe some other features of high cardiac output could be something that you could see in their presentation of the vignette. All right, let's move forward now and talk about the diagnostic approach and just put all of this information together in a nice algorithmic way. This is a lot of stuff, right, from microcytic anemia, but I think whenever we kind of get our vignettes and we're trying to analyze the question, I think we can think about it in this particular way, putting everything together that we've learned. Let's say that we have a patient who we get a CBC, a reticulocyte index, off of the vignette. And when we do that, we see, oh, reticulocyte index is less than 2%. Okay, well, what the heck does that mean? Oh, that means that my bone marrow is not working. All right, well, pretty much all of them, the bone marrow wasn't really working. Maybe thalassemia, the bone marrow was struggling a little bit, but it was also hemolyzing the red blood cells, right? So that's really important. So in an underproduction anemia, the red bone marrow is not really working. And so it's struggling to produce red blood cells, right? And one of the first parts before you get a mature red blood cell is this thing called a reticulocyte. So you always go in it from a stem cell to a blast to a reticulocyte to a red blood cell. And a reticulocyte is basically that last stage. In about 2 to 3 days, it converts into a red blood cell, so it completely matures. So reticulocytes are nice because it gives us a gauge if the bone marrow is actually producing red blood cells before we actually get those red blood cells that can register on the actual lab value. And so if a patient's reticulocyte count is down, that means that their bone marrow is really struggling to make red blood cells. And so erythropoiesis is being ineffective. So that's one of the really interesting things, is that I can tell if this is occurring here in this scenario. So iron deficiency anemia, sideroblastic anemia, anemia of chronic disease, all of these exhibit that problem where they struggle to produce red blood cells. Even thalassemia struggles in the production of red blood cells because it doesn't have the globin chains. But what's really important to remember is that thalassemia also has hemolysis. And so when a patient has a reticulocyte index greater than 2%, it means that their bone marrow is working. It just means that they're destroying the red blood cells that's in the circulation, right? Either they're losing them or they're ripping them apart. Hemolysis. Thalassemia was undergoing hemolysis. So in other words, the patient has the ability to compensate and tell their bone marrow, hey, increase the production of reticulocytes. And then over time, that'll mature into red blood cells. And again, this is going to be the first one that will go up before this one will go up. So if the reticulocyte count is high, it tells me that my bone marrow is working. Almost all of the microcytic anemias, with the exception of thalassemia, should all have a reticulocyte index of less than 2%. All right? Even thalassemia at times can have a reticulocyte index of less than 2% unless it's hemolyzing. So in other words, unless it's in that hemoglobin H stage or the beta thalassemia major stage. All right, so I get the CBC, I look at the retic index. That could give me somewhat of an idea, especially if a patient has anemia. Is the patient exhibiting some type of underproduction or blood loss or hemolysis? So let's now take this into consideration and go to the next step here. Patient has a hemoglobin less than 13. They're a male. Okay, that's anemia. Patient has a hemoglobin less than 12. They're a female. That's anemia. So right away, I have anemia. From the next part, before we actually look at the reticulocyte index, I like to then go to the next component. We're going to add these in a little bit after, but it's always nice to kind of get a basic discussion of them. If I check the MCV, that should tell me what type of anemia I have. If it's greater than 100, that's macrocytic. If it's 80 to 100, that's normocytic. And if it's less than 80 femtoliters, that's microcytic. So far I have a microcytic anemia based upon the hemoglobin and the MCV. From here, that's where I could take a look at the reticulocyte index. What you'll find though is that most of the microcytic anemias will have a reticulocyte index of less than 2%. If you have a microcytic anemia with a reticulocyte index of greater than 2%, it could be thalassemia undergoing some of that hemolysis going on, right? All right. But even better than the reticulocyte index to determine which type of microcytic anemia we have is iron studies. All right, but before we get to that, there's another test that we can look at in our indices, our red blood cell indices, and that's called the red blood cell distribution width. It tells us of the different sizes of red blood cells. This sometimes will come up on your exam. So iron deficiency anemia and sideroblastic anemia tend to have an increased red blood cell distribution width, whereas thalassemia and anemia of chronic disease, they don't tend to have as much of that differentiation in sizes of the red blood cells, so the red blood cell distribution width tends to be on the normal range. All right. So again, iron deficiency anemia, sideroblastic, increased red blood cell distribution width. All right. We got our CBC. We see the hemoglobin. It suggests anemia. MCV, less than 80. Almost all of the microcytic should have a retic index less than 2. Out of all of these, which one should have an increased RDW? IDA, sideroblastic. Which ones have a normal? Anemia, chronic disease, and thalassemia. But what's the best test to really go with here? Iron studies. When I obtain iron studies, there's a couple different things that you look at. You look at the iron, you look at the ferritin, you look at the transferrin saturation, and you look at the TIBC. All right. When I look at these, the first thing I like to know is what's the iron? If the iron's low, what this tells me is that it's most likely to be either iron deficiency anemia or anemia of chronic disease. And these problems here, a patient wasn't getting enough iron across the GIT, right? Or they're losing iron from their bloodstream, or they're consuming more iron than they have available, right? But there's low iron in the blood. Anemia of chronic disease. Their hepcidin is shutting down the GIT or shutting down the macrophages from liberating iron into the bloodstream. That's the problem here, right? Now, the next level of challenge is to say, okay, iron deficiency or anemia of chronic disease. How do I know which one is which? Check that ferritin level. So ferritin tends to be low in iron deficiency anemia because it's the protein that binds to iron in the cells. If iron is low, you're going to have less of it bound to ferritin. TIBC, which is the total iron binding capacity, is elevated. And this is usually a result because of, again, the liver tries to compensate and increase the amount of transferrin, which is a protein that kind of binds to the iron and transfers it to different tissues in the body. Your liver will compensate and really try to push up the transferrin production, which is our TIBC. All right, so in iron deficiency anemia, the liver will say, all right, I see that the iron's deficient. Let me increase the amount of transferrin so that if there is any iron, I can transport that to the tissues as well as I can. Problem is that the transferrin saturation, the amount of iron that's bind to the transferrin, is low because we don't have as much iron. So these are the ways that define iron deficiency anemia. Anemia of chronic disease. Do you remember what I told you whenever there's lots of inflammation? It definitely causes less iron to be released into the bloodstream by the GIT and by the macrophages. But what else did I tell you that inflammation does besides increase hepcidin? It increases the production of an acute phase reactant protein called ferritin. So ferritin levels should be elevated. The other thing is that because of all this inflammation, the liver shuts down its production of transferrin. And so TIBC tends to go down because we have less of that transferrin being produced by the liver. On top of that, the transferrin saturation goes down because you have less of the transferrin and less of the iron that's available to bind to it. And so because of that, this is what establishes most likely the diagnosis of anemia of chronic disease. All right? Now, if the iron is normal or a little bit elevated, this is more likely going to suggest a sideroblastic anemia or a thalassemia. And I think this works really, really well with sideroblastic. So in sideroblastic anemia, the problem oftentimes exists that you struggle in being able to incorporate the iron into the protoporphyrin to make heme. And so sometimes the iron levels can be completely stone cold normal, or some of those cells will die and the iron can leak out into the bloodstream. So the iron could be a little bit elevated. But oftentimes if the iron is completely normal, or if it's just a little bit elevated, it really suggests these two, because these have no bearing whatsoever. If you go back to their mechanism, no bearing whatsoever on the iron levels. No bearing. All right. So it should be normal or maybe mildly elevated. All right, because they're not utilizing the iron in the actual mitochondria of the stem cells. All right. Now, with that being said, between these two, do I take and look at any of the other components here? I don't really need to because it's not going to help me. What I really want to do at this point is look at my peripheral blood smear. The reason why is if I look at the peripheral blood smear and I see these target cells, and then on top of that, I combine that with a good history and physical. The patient has maybe some type of hepatosplenomegaly. Maybe they have a family history of anemia, or they have frequent anemia that's requiring transfusions. That highly, highly suggests thalassemia, right? And that's what I want to know is, do they have thalassemia? The only way that I can determine if a patient has a type of thalassemia is to get a hemoglobin electrophoresis. Now, if you remember, the alpha thalassemia with the hemoglobin H, right? That one, again, you'll present with the hepatosplenomegaly. Maybe you'll have some hemolysis that's going on. The beta thalassemia major, though, That one will present with hemolysis. That one will present with hepatosplenomegaly, but really look out for the facial and cranial abnormalities, the hair-on end appearance, the frontal bossing, the depressed nasal bridge, the exposed upper teeth, the hypertrophy of the maxilla, and the periorbital puffiness, right? Those were features that suggested that. But the hemoglobin electrophoresis is going to be the best test that you can go with. The reason why is it's going to take a look at the proteins. It's going to take a look at the different types of hemoglobin that are present, all right, and what's not present. Oh, that will be very helpful. So in hemoglobin H disease, guess what? That was when you didn't have as much of those what? The alpha globin proteins. And so what counteracted that to try to compensate? Beta globin tetramers. When beta globin tetramers form, they lead to this presentation of hemoglobin H. Sometimes this can be seen on the electrophoresis, and sometimes it can't. Oftentimes, what you'll see in the exam is that alpha thalassemia, they tend to have a normal hemoglobin electrophoresis. So there's nothing that really kind of spits out. You may get lucky sometimes, and they may pick up this hemoglobin H, which is the beta globin tetramers. The test that, or the finding that you'll more likely see utilizing the hemoglobin electrophoresis is for beta thalassemia major. In this one, you'll see a lot of hemoglobin F, and you'll see a lot of hemoglobin A2. Now, I want you to think back to this. Okay, so beta thalassemia majors, you didn't make any beta globin chains, right? What did you have to compensate with? Alpha globin. Now, there was hemoglobin A, which was alpha beta, hemoglobin A2, which was alpha delta, and hemoglobin F, which is alpha and gamma. If you don't make any of the beta, you probably won't make any of the hemoglobin A. And so the hemoglobin A will be really, really, really low. But you do have the alpha to combine with what? Delta, or gamma and delta. And so you'll increase the expression of these other hemoglobins to compensate for a deficiency in hemoglobin A. And so when you look at the electrophoresis on this, that's what really was suggested. So here, let's say that we have a normal hemoglobin electrophoresis. Here's the hemoglobin A2, here's the hemoglobin F, here's the hemoglobin A. You look at a patient with beta thalassemia major, now what are you going to see? A thicker band on the hemoglobin A2, a thicker band on the hemoglobin F, and a very, very tiny band for hemoglobin A. That's what would suggest beta thalassemia major, all right? Or really any kind of beta thalassemia, preferably. That's going to be the key diagnostic clue, all right? Now, if I got the peripheral blood smear and I see this basophilic stippling, so let's say that I zoom in here, you see these guys here, if I zoom in on them, I'll be able to see all those like little dots. That's really, really high yield, right? So basophilic stippling is very, very highly associated with sideroblastic anemia, right? Now, the big thing is if I see basophilic stippling and I don't see any ring sideroblasts, or if sometimes you can see them on peripheral blood smear, but they're more likely to come up on a patient's bone marrow aspiration. But if I have a patient who I have a strong degree of suspicion that they could have lead poisoning and they have basophilic stippling, they have the lead kind of features. Remember I told you about those, the lead lines, right? The encephalopathy, the abdominal colic, the drop wrist or drop foot. I'm going to check a lead level. So any kind of basophilic stippling with those features, check a lead level. Just make sure that it's not elevated and it's a lead poisoning toxicity. Another finding that's really suggestive of sideroblastic anemia is Pappenheimer bodies, which are these kind of iron-containing stains that you can see on a standard right stain. They're all these little guys right there. So you see these right there. These are very, very highly suggestive of Pappenheimer bodies. All right. So if I have sideroblastic anemia, I'm highly, highly suggesting that it's probably this. But what would I need to do to confirm? So hemoglobin electrophoresis was the confirmatory step for thalassemia. What's the confirmatory step for sideroblastic anemia? That's where I would need to do a bone marrow aspiration. When I take that, I'll look at the cells under the actual microscope, and I'll put a Prussian blue stain on it. And if it shows these ring sideroblasts, which is all the iron just accumulating around like the actual nucleus, this is super, super suggestive. This is because I can't utilize the iron, right? All those enzymes are inhibited. And so since the enzymes are inhibited, or they're not present, or they're not there at all, I'm not going to be able to make functional heme. And so iron builds up inside of these cells. Isn't that crazy? So this is super, super suggestive of sideroblastic anemia. So we have diagnosed the type of microcytic anemia. How do we then say, okay, I've diagnosed it. How do I treat it? Well, with most anemias, it's really important to know when you should transfuse a patient with red blood cells to get their hemoglobin back up. And those blood transfusions, it's really important to know this little nugget here. that for every 1 unit of packed red blood cells that you give a patient, it should increase the hemoglobin by 1 gram. So let's say that you have a patient who comes in and their hemoglobin is less than 7, they're hemodynamically stable. So they have hemoglobin of 6. If I want to get their hemoglobin at least greater than or equal to 7, what do? I give them 1 unit, right? That's it, done. If I have a hemoglobin of a patient less than 8 and they have pre-existing coronary artery disease and they're somewhat symptomatic, I will give them what? Let's say that they have a hemoglobin of 6.2. What would I do? I would give them 2 units to get them to 8.2 to be greater than 8. If I have a patient who has an acute MI or severe symptoms, severe symptomatic anemia with a hemoglobin less than 10, what do? And it's 6.2. I would give them 4 units of hemoglobin, right? Or 4 units of packed red blood cells to get their hemoglobin up to 10.2, greater than that threshold. What if I have a patient who is hemodynamically unstable and they have acute anemia from blood loss, they're in hemorrhagic shock? Then what do? I give them blood until they're no longer hemodynamically unstable and then treat the underlying reason. So I get them to their hemodynamically stable and then send them to the OR or whatever kind of like field they need to go to get the underlying issue. So for example, if they have a GI bleed, I'd have to reach out to GI to go and scope the patient or to send them to IR to embolize the vessel, whatever it may be, or do an X-lap to figure this out. But I need to get their blood pressure up to a normal level, get them out of shock with just as much blood as I need to, and then once I've done that, then reach out and treat the underlying cause. So those are the big things. Hemoglobin less than 7 if they're asymptomatic, hemoglobin less than 8 if they have CAD, hemoglobin less than 10 if there's severe symptomatic anemia, especially an acute MI, and then any hemoglobin level, regardless if they're in hemorrhagic shock, you give them blood until they're no longer in shock. All right? Now, what about iron deficiency anemia? So we treat the underlying cause and then give them blood to get them asymptomatic or get their hemoglobin to a level where they're getting enough oxygen carrying capacity where they're no longer symptomatic or in shock, etc. So iron deficiency anemia, you treat the cause. So in other words, if they have a GI bleed, guess what? You're going to maybe have to do a colonoscopy or maybe an upper endoscopy, depending if you think it's peptic ulcer disease or if you think it's colorectal cancer. If it's an abnormal uterine bleeding, maybe you'll have to go ahead and put them on contraceptives or do some type of examination to figure out what's the source of their abnormal uterine, maybe get a transvaginal ultrasound, right? The other component here is preventing, getting them a sufficient amount of iron in their diet. So what we'll have to do sometimes is put these patients on oral ferrous sulfate. And so that's going to be the first line. So we usually do that 325 milligrams of ferrous sulfate with some vitamin C to help to increase the absorption of the iron. Now, in patients who maybe have like a problem being able to consume the iron, so they can't take it in because it tastes terribly, or they have a lot of GI upset or side effects, then maybe we'll go with IV iron. Right? If they have a malabsorptive syndrome where I give them iron, they don't even absorb it, I may have to do it in that scenario. Or if they have severe iron deficiency anemia, then I may have to go ahead and do IV iron and then eventually transition them over to oral iron. All right? Anemia, chronic disease, it's all really about treating the underlying disease. Treat the inflammation, treat the disease process. So if they have some type of SLE, RA, maybe immunosuppressive therapy. If they have cancer, maybe you have to do chemotherapy, surgical processes. If it's a patient who has anemia of CKD with a hemoglobin less than 10, this is under the guidelines of suggesting the utilization of erythropoietin. So erythropoietin is basically a hormone that you can give the patient because in patients who have CKD and they don't produce enough EPO, they don't make red blood cells, right? If I give them exogenous erythropoietin, it should counteract this and flip the EPO up and flip the red blood cells up. And so that's kind of the design that I would give only if a patient has anemia of CKD with a hemoglobin less than 10. You don't do this if it's anemia due to SLE or RA or cancer generally. We don't do ESAs for those reasons. We only really treat the underlying disease in those, and then EPO if they have anemia of CKD. Now, sideroblastic anemia, it's about treating the underlying cause. So you have to go back, DC the medications. So linezolid, if possible, maybe switch to something else, vancomycin. Chloramphenicol, switch to something else, doxycycline. Isoniazid, maybe switch to an alternative medicine instead of isoniazid, or give them B6 while they're on isoniazid. In other scenarios, if they have lead poisoning, you may have to give them lead chelation. So dimercaprol, EDTA, maybe some of those potential drugs that you can give to chelate the lead. In patients who have B6 deficiency, whether it's dietary or isoniazid related, or whether it's a genetic problem, so they have an X-linked defect where they have a decrease in ALA synthase activity. In this scenario, what I want to do is I want to give the patient B6. The reason why is if I give them B6 and it's due to a decreased ALA synthase enzyme activity or B6 deficiency, if I give them B6, I will amplify the activity of ALA synthase. If I amplify the activity of heme, it will help to amplify heme synthesis, which will help to increase the hemoglobin. So this would be good only for inherited or genetic defects, as well as B6 deficiency. That's really, really important. For the next one is thalassemia. Now, thalassemia is really, really important. And the reason why, when we talk about thalassemia, it's really about treating the underlying cause, right? So this is some type of mutation in the hematopoietic stem cells where on chromosome 16 or chromosome 11, they decrease the expression or they don't produce any of the globin chains. And so therefore, they don't make proper hemoglobin, they don't make good hemoglobin, they don't make good red blood cells. So if I just replace that stem cell with a new stem cell, a bone marrow transplant per se, that should cure this potential scenario. Now, unfortunately, because these patients experience a lot of hemolysis, they can end up undergoing splenomegaly, and eventually their spleen can kind of turn into a sequestering factory, and they can have hypersplenism where they develop rapid drops in hemoglobin or thrombocytopenia. In those scenarios, sometimes we have to cut the spleen out if they're having a lot of hemolysis. So we'll go in and we'll tie that puppy off and remove it. So that may be a reason to sometimes do a splenectomy, is if they're having significant amounts of hemolysis that's causing splenomegaly or hypersplenism. Another thing is whenever you have a patient with thalassemia, right, especially hemoglobin H disease and beta thalassemia major, what is the spleen doing in compensation to the hemolysis? It's increasing the production of red blood cells. So extramedullary hematopoiesis can also cause these spleens to get enlarged. So if a patient is developing splenomegaly or their spleen is turning into a sequestering factory, you may have to cut that puppy out. But that would be the indications for this. All right, the last thing that I want to talk about is in patients who have thalassemia and sideroblastic anemia. Sideroblastic anemia, they're already high risk of having a little bit of iron elevation, all right? Because again, the iron can't be incorporated into the protoporphyrin to make heme. And so iron kind of builds up and it can get into the bloodstream. So they're at high risk for secondary hemochromatosis. Thalassemia patients, they have severe anemia and oftentimes require frequent blood transfusions. So if a patient has sideroblastic anemia or thalassemia and they get a blood transfusion, any kind of like potential cause where they're getting frequent transfusions, when you give blood, you give hemoglobin. When you give hemoglobin, you give iron. When you give iron, you can cause iron toxicity, and that can lead to this hemochromatosis picture. So if a patient who has, and I say this especially, thalassemia or sideroblastic anemia, and they're getting frequent transfusions, you need to initiate iron chelation therapy with those blood transfusions. You can't do phlebotomy because you're undoing the whole process. So in these scenarios, we'll give them iron chelation like deferoxamine, because what it's going to do is any of the excess iron will get bound up by the deferoxamine. You'll make this complex, which then can be renally excreted. And so then you drop the amount of iron, but make sure that they get enough hemoglobin. So that's the last thing that I want to add here for the treatment of microcytic anemia. So again, any anemia where the hemoglobin is less than 7, transfuse. Hemoglobin less than 8 with CAD, transfuse. Hemoglobin less than 10 with severe symptomatic anemia, like an acute MI or other types of symptoms, transfuse. If they have hemodynamic instability, you transfuse until they're hemodynamically stable. If they have iron deficiency, oral iron if possible. IV iron if they can't tolerate a malabsorption disorder, or severe iron deficiency. For sideroblastic, what do? You give them B6 for the inherited types, or you also can give them what else? You can potentially just discontinue the underlying trigger, which is the medications, right? For anemia chronic disease, you treat the underlying cause, erythropoietin only for anemia of CKD less than 10. For thalassemia, splenectomy if they're having lots of splenomegaly, hypersplenism from hemolysis or extramedullary hematopoiesis. Otherwise, bone marrow transplant. And lastly, in patients who have thalassemia and sideroblastic anemia, they're at high risk for secondary hemochromatosis. How do you prevent this? You give them an iron chelating agent. Because again, features of hemochromatosis could be like cardiomyopathies, it could be hyperpigmentation, it could be diabetes. So there's a lot of different presentations that you have to be watching out for, and especially sometimes even cirrhosis. So it's really important to make sure that you give these patients iron chelating agents if they're getting overloaded with iron. All right. My friends, that covers microcytic anemia. I hope it made sense. I hope that you guys enjoyed it and loved it, and love you. Thank you. And as always, until next time.